Well, welcome everybody. It's just 1 minute after 1, but I can see that we already have a quorum here. So I'll go ahead and kick off our brown bag lunch today. My name is Kevin Croak. I'm Assistant Professor of Global Health in Department of Global Health and Population. I'm very pleased to welcome you all to our Global Health and Population brown bag seminar talk. And we're very lucky today to have as our guest the Commissioner of Health for Ekiti State in Nigeria, Dr. Oyebanji Filani. Dr. Filani has many years, over 17 years experience as a physician and health economist in Nigeria and globally. He's currently Commissioner of Health and Human Services in Ekiti State, as well as Chairman of the Nigeria Governors Forum of Commissioners of Health. He was previously a technical director for the Basic Healthcare Provision Fund in Nigeria, and prior to that, a senior technical advisor to the Minister of Health with a very broad portfolio of health financing and health reform and primary health care and routine immunization issues. So really just a broad range of experience both there and before that. So we're very pleased to have him join us, and I'll just hand the floor over now to you, Banji, and we're just looking forward to this talk. Thank you very much for joining us.
Thank you very much, first and foremost, Kevin, for the invite, and thanks to all who are able to join. I will try to take you through very quickly just a bit of a background about Nigeria for people who may not be too familiar with that, but then delve in very quickly into Ekiti State, where I happen to be the Commissioner for Health, and then zoom out again into Nigeria. So it allows us to see, the experiences really from Ekiti State in terms of what we've been able to do over the last 2 years that I've been in office. So just give me a moment. Yeah, exactly. So in terms of content, I've structured it across 4 places where we want to be as a country, where we really are at the moment, taking examples from Ekiti State. And then, of course, our approach to strengthening the health system from Ekiti State and what we consider for Nigeria and also for Ekiti State, the next steps. So for those who may not be too familiar with Nigeria, it's a federation with 6 zones. I've tried to color code the zones accordingly, 36 states, 1 federal capital, 774 local government areas, which are like districts, 900, just a little under 10,000 wards. And Ekiti has been pulled out there with a population of about 3.6 million persons. So it's in the western part of Africa. As a country, Nigeria is unique in itself, and it's one that has very distinctive people, culture, and heritage. For those of you who may love music or may understand music, you would see that Burna Boy is probably our latest export. Kevin, I think your line is okay. Great. So you would see that Burna Boy is probably our latest export, and one of the things that as a country we push out fairly globally. But it's also Nigeria, it's also Africa's largest economy as a country, middle income, mixed markets, broadly diversified with a large working age group. In terms of trade and industry, again, like I mentioned, because it's broadly diversified, we're into manufacturing, agriculture, but also interestingly, we're the 2nd largest producers of movies in the world. Just in terms of fun facts for Nigeria. So for a country of our status, covers just a little under 50% of West Africa in terms of population, the boisterousness, the zeal, the push, it should be a country that should be able to, deliver a world-class health system to meet the needs of its population. And in terms of the health status, the quality of care that we provide should be solid enough, should be able to reduce inequity to health access. The health that we provide should be responsive, right, to client demands and need. We should be able to offer financial protection, which essentially means that when people go for services, they do not have to, suffer any sort of financial hardship to receive care. And then in itself, the system must be efficient enough to be able to utilize resources in an optimal manner that allows us to get most bang for the buck. And of course, if you're able to do all of this, then we can move towards our goal of achieving universal health coverage by the year 2030, in line with the broader SDGs. Oftentimes, I tell people to imagine a Nigeria which gives us a future, right? And what the story looks like. I imagine a Nigeria in 2029, where just at the cusp of achieving, at the cusp of declaring the SDGs in 2030, that we're able to say that we've achieved SDGs and we've been able to meet our target for maternal and infant mortality rates. But the reality is a bit different, right, from what we currently see. And I'll take a look at what we see in Ekiti as an example of the realities, particularly when I came in late 2020 as a commissioner. And so Ekiti in itself, 16 local governments. We have a new governor who's just done a little under 1 month in office. He became a governor on the 16th of October. Ekiti has a population of about 3.6 million persons. You would note very clearly that if it was a country in itself, it's about a low-income country given the GDP per capita. But some interesting fun facts about Ekiti: it's the state with the highest number of professors per capita, possibly the highest number of professors per capita per area in the world. That rivals Boston, I would assume. And also Ekiti has, for each of the towns in Ekiti, it has a suffix, right, for Ekiti. So you have Ikole Ekiti, you have Oye Ekiti, and it's home to the Ikogusi Warm Spring, one of the global heritages or resort sites in the world. Ekiti has, like I mentioned, the governor who was sworn in on the 16th of October. But I think this is really important because he got sworn in on a Sunday. The first task he did was to appoint a commissioner for health, which was my own reappointment. And I think it's a credit to him with respect to his focus on health, but also more broadly on human capital. I come in with a fairly decent degree of execution and some of the work that I've done in the past with respect to health sector reforms. But we also have a dedicated service, civil service. We have a group of people who are keen and willing to work to ensure that we're able to achieve our vision for a state that's, minimizes preventable death and is able to provide a good, solid package of care for all citizens. In terms of the health system in Ekiti, we have 3 tertiary hospitals. I think we're one of the very few states in Nigeria that has a federal teaching hospital, has a state teaching hospital, but also has arguably the biggest and best private multi-specialist hospital in the state. We have 22 general hospitals, and then we have, a mix and match of primary healthcare centers. So ideally, for a state of 3.6 million people, we should be able to, in terms of geographical spread, we should have the access shouldn't be really a problem. But then what you see in terms of what is happening in Ekiti is that our infant mortality ratios, under 5 mortality, and of course, in terms of outcomes are not as great. And I've compared Ekiti with a number of the states also in the southwestern parts of Nigeria. This data is from 2019. 2019. So just a year before I became the commissioner for health. Again, if you look at not just the outcomes, but also if you take into some of the outputs, right, or coverage numbers, you see that we're not doing as great. Treatment for malaria with ACT being the drug of choice for treating malaria, is far lower than most of the other states. And there are reasons for that. Some of these reasons are adduced on the next slide. Essentially, the reasons I've categorized the reasons around outputs and outcomes under 3 key buckets, right? There are low demand for services, there are low availability of quality services, and there are issues around the governance in the system. What I have done is to highlight specific areas where we've done some work, because we've realized that those are areas where we've had this significant challenges as a state. So if you look at under the low demand for services bucket, the low client and poor health practices are not as much of a problem in the state as compared to the low financial protection. The same with the availability of quality services. We realized very early on that our commodity supply chain and drug management system was pretty poor, and so we needed to address that. And so I'll just speak to some of those things. Again, like I mentioned, in terms of the financial protection, if you look at government expenditure for health as a percentage of general government expenditure, which is the first chart on the upper left, you realize that we were only spending 8% of government health expenditure as part of as a total of the general government expenditure. our expenditure for primary healthcare versus hospital services was 12%. So of all, so first and foremost, we're spending only 8% of government funding on health. Of that 8%, only 12% of that was going to primary care. And for us, where primary care is where almost 73%, just a little under 75% of health services or utilization requirements are carried out or can be addressed at a primary healthcare service. So it's a really warped system. Our capital to recurrent also wasn't great, very low spending on capital, which meant that our ability to be able to invest appropriately was poor. But also more importantly was that beyond what government was spending, but just even generally more importantly was that 73% of spending in the state, right, was out of pocket. And for a state where again, if you look at it, when I talked about the per capita income, it means that a lot of people were spending out of pocket and probably was pushing them to poverty. Within the facility, we looked at, the sources of operational fund within the facility, and we realized that, just from registers of about 173 facilities that was done when I came in 2020, only about 5 of them received any sort of funding from government. And so they resorted to alternative sources of financing using the charging patients for drugs, charging patients for registration fees, and then some sort of staggered donor support. So it begins to paint a picture where there's not enough resources in the system within the primary facilities or within the facilities. What we then begin to see is underhand or under the table, use of extortion, if I could use that word, right, to collect funding from patients. And invariably, that means that people are likely to bypass, right, the facility to receive care, or, maybe forced to then sell assets just to be able to access care. Again, when you move away from challenges within the demand and then you go into even if the demand has been sorted out, but what does the facility look like when people go there? So if I have the resources and I'm willing to pay, what then happens at the facility? And then when we saw, again, in 2020, when this assessment was done, was most of our facilities did just not have, the essential commodities to be able to adequately take care of patients. So almost 34% of our facilities, only 34% of them had essential commodities. And these essential commodities are things to treat, upper respiratory tract infection, malaria, which is endemic within Nigeria, and a few of the other very minor ailments for children, or also even for pregnant women, right? So it was a challenge for us as a government, particularly when we came in and we needed to start thinking through what was the way to address some of these concerns. Of course, I got a double whammy as I was coming in. That COVID also said, well, I would accompany you into the States. Let's see what you can do. Obviously, at that time, it meant that the underbelly of our health system was further exposed, because then we had healthcare workers who were spending disproportionate time trying to address patient needs, but also meant that people didn't even attempt to come to facilities. So utilization even dropped further. So what we did, and first and foremost, was to, rethink what needed to be done, right? What was the theory of change? What did we see as a challenge, and how are we going to address it? And so we had an overall vision to improve health outcomes and well-being for everybody in Ekiti State, with a very clear goal around zero preventable deaths, but also strengthening our public health preparedness, right, to respond to emergencies going forward. We had very key strategic interventions. The bolded ones are the ones I would speak to, because they also speak to how we addressed the problems. And then there were some cross-cutting opportunities that we thought was clear in terms of, leveraging on innovation, technology, and just multi-sectoral collaboration, either with partners at the federal level, our agencies at the federal level, or across other sectors in the state, or even with our partners, right? And in doing that, we did really 3 things. Again, to address the issues around quality of health services, we focused around a drug management agency. So to strengthen, to minimize impact of future public health emergencies, we had to really work around our public health emergency system to ensure that it was responsive and had the capacity. We trained our staff and capacity to be able to address issues appropriately. And we did a real solid reform around our health financing, making sure that we could institutionalize a sustainable way to financing healthcare in Ekiti State. So I'll delve into each of these a bit, just to share some of the work that we did and how we went about it. With quality, with drugs, it was important that first and foremost, we wanted to take stock of what the existing supply chain looks like. And that's allowed us to run the analysis, right? Starting with the procurement processes, how we did our quantification, what our warehousing looks like, and how the drugs moved down to the facility. So it was important that that was done. And then we explored what opportunities were there to optimize our supply chain system. But also beyond that was to then have, first and foremost, we realized that we didn't even have a law around the drug process. So we needed to set up we put together a bill, and we needed to pass that bill so that we could have something called a drug management agency. But beyond having the agency in itself is to ensure that that agency is able to function optimally. So we capitalized it, and also ensure that the agency dealt directly with manufacturers. So not third parties, not brokers, but manufacturers. And that allowed us to guaranteed us the quality in the drugs that we got, but also ensure that we could guarantee, the consistency in pricing for an extended period, and then pass that on to the facility and ensure that those facilities have drugs at all times when patients come in. So this was when the bill was signed. In the middle there, again, as you will see, this was in the peak of COVID. In the middle there was the immediate past governor, myself, and the lady on the right, on the left rather, well, on the right is as a chairperson on the House Committee on Health, right? So you could see that it was real collaboration to ensure that we could pass the bill. And His Excellency signed this in late 2020. I think it was 2 or 3 months after I came into government. Immediately that was signed, we set up the drug management agency, and we ensured that we began to meet with the drug manufacturers. So this was us signing with drug manufacturers to ensure, and we locked in. That allowed us, because we had capitalized, we could buy in bulk from them. And so it guaranteed, again, like I said, the quality of the drugs. We locked in prices for extended periods. And that allowed us to reduce stock out of essential commodities at the facility level. But I also think, interestingly, because this goes to people in finance, what they often want to know is, okay, you've set this up. What are the guarantees that it can run on itself without having to recourse to government every other time for additional capitalization? And the beauty of that is, in 2020, before it came on, and now I think it was doing, the revenue was about $400,000. In 2021, well, between 2021 and in the last 1 year, essentially, it's done over just about $1 million in terms of revenue generation, because again, it was properly set up. We've put the right people in place. They're following up and aggressively ensuring that all facilities in the state are able to buy from, or must buy, because it's part of the law, must buy directly from the DMA. The drugs that they get are far cheaper because they get it directly from the manufacturers, and that doesn't take into consideration any sort of markups that brokers or wholesalers would have put in. On the second thing then, of course, was the public health emergency response. I think for us, it was critical that, because of the way COVID was, and in Nigeria, for people who may not know, over the last decade, there's been one epidemic plus X. So it's either we have like Lassa plus another one, or you have a monkeypox plus another one. And so for me, I thought it was important that in addressing the public health response, we didn't think about COVID alone. We had to think about it a bit more holistically. COVID provided the opportunity for us to drive these key reforms. And so we devolved the Emergency Operations Center, which really is sort of like the thinking unit within within a public health emergency system, right? We devolved it down to the district level, giving them the powers and authorities to be able to act, embedded rapid response teams within them, and if there were challenges, they could cascade very easily. When COVID came in with the vaccinations, we had very interesting ways to address that. We set up a management system leveraging on technology to do two things. First, for testing, but also in terms of those who had given the vaccines. We captured everybody's data, and where we saw and gave them the opportunity to report AEFI, so adverse events of any sort. And then finally, we just generally trained our teams to improve the surveillance and capacity, and also their capabilities. This is the one I talked about. So the LGA at the EOC haven't been decentralized, and they were able to have regular meetings. They had rapid response teams, which are a group of people who go into the community to respond to public health emergencies at that level. We also decentralized the testing method. So rather than tests, take on test and then bring it down to the capital to make sure that you can get your results. By the time the rapid kits came, we decentralized that. So people got their results much faster. Those who were unwell knew that they had to isolate. Those who were well were free to move forward with what needed to be done. And so that really helped us, manage and minimize mortality for COVID. With the vaccine, again, I talked about it. We set up a post-vaccine tracking tool. Like I mentioned, over 37,000 persons registered on it. We're able to get just a little under 3,000 responses, and clients were reporting, those who had AEFIs were reporting. So it was useful for us because, again, we could know what sort of drugs, the vaccines they took, whether it was the AstraZeneca or the Pfizer or the J&J, and the key adverse events that they had, how they reacted to it. And that gave us a sense of how quickly we could address those issues, where we could send them to. It was quite an interactive one because it had a WhatsApp component as well. And because of this, again, in addition to this, we also, in terms of the way people went out to vaccinate citizens, we changed the way. When we started paying, we just paid them a blank sum at the beginning of the month. At the beginning of the week, right, to go out. But to improve that performance, we changed it to, if you are able to vaccinate X number of persons, then you get a sort of like a stipend. And as of today, we've hit about 74% we've surpassed the national target. I think that's the important thing. The national target is to hit, for us, was to get to 70% of our eligible population by December. We've already surpassed that. So there's been quite a lot of effort in this regard. Finally, again, I talked about the capacity in terms of building. So we have better reporting because we decentralized to LG level. So the reporting is much faster. We report on a national platform called SUMMERS. And as you can see, the award very clearly, we were judged for the 4th time, the best performing public health response team in the entire country. So that allowed us to, that speaks to what we've done to address not just COVID, but a chunk of this, the lessons learned here, the knowledge, the capacity remains, right, for us to be able to address any of the other potential emergencies or epidemic that may break out. The final thing then speaks to the health financing reform. And for us, it was important that we define very clearly at the beginning an explicit package of very high impact interventions. So we now have, doing a really thorough job. We have an explicit package that covers about 57 critical interventions delivered at a primary healthcare centers that addresses 70% of our disease burden in the state. And the goal is for us to be able to provide that free at the point of use, covered by government, to every single citizen in the state. So we started a pilot of this, and I'll share some insights as well as we move forward. Of course, in the pilot phase, we had to train staff. We had to ensure we engage the community appropriately, just to create that awareness. And then we developed a platform, an IT platform, for us to be able to bill, for the facilities to be able to bill, to submit invoice, and then for us at the insurance agency, or for the team at the insurance agency, to approve or reject the claims that have been sent, and then to generate payments. And it's been quite an interesting 6 months that we've had this done. This is what the platform looks like. At the facility end, it's the left side. You see where they're able to put a patient's ID. They can have the facility name, the date of the visit, the diagnosis the patient has come in for, what services were rendered, and then of course there's a tariff for each of the services that is delivered. On the other side of it is what the reporting looks like. So on the click of a button, I can see either by LGAs, or even if I want to look at it from a service rendered perspective, it gives me that opportunity to play with it. The team that works on this sits down very regularly just to review and approve claims, ensure that the data validation to minimize errors is done, and that they're able to process the payments on a monthly basis to give the facilities the opportunity to, continue to attend to our patients. So what is the next step? We've talked about a number of issues that we've had in the state. We've talked about challenges with respect to commodities from a quality of supply side perspective, and how we've addressed that using our drug management agency and setting that up. We've talked about responding appropriately to the public health response, and how we've built capacity of the team, and how that team has been recognized at the national level. We've also talked about the work that we're doing to expand our health insurance reform and targeting about 1 million people, which is a third of the state essentially, by 2025. Our immediate next step is to scale up the program, ensure that the DMA the Drug Management Agency continues to work well, but also to renovate its current warehouse and to continue on the path of a really strong political will to build world-class health services for Ekiti State and its people. And taking off from this, it's important to then see, how does Nigeria then learn back from Ekiti? And there's a lot that we've done. How can we take this back to the country in itself? Because I chair a forum of all 36 health commissioners in Nigeria, we have recently set up something called the Nigerian State Health Leadership Collaborative, which essentially allows us to, it's like a committee of practice, but allows us to address, a common set of challenges and agree on transformational opportunities. And the Nigerian State Health Leadership Collaborative really focuses on 3 things. First, there's an annual PHC forum. The second is a top team effectiveness learning platform. And then the third is a quarterly collaborative of a meeting of health commissioners. Underpinning this, of course, will be health financing data and analytics that we would use to hold ourselves accountable. Just last month, in October, we had our first PHC financing forum. It was very well attended. Over 700 people online and in person joined with very clear deliverables. And some of the next steps are to reconvene to be able to share and consolidate data, establish a working group amongst primary healthcare, a PHC working group, engage more with the local government authorities, engage with our commissioners of finance to close the loop and gap between health and finance, but also to make sure that we're able to, report appropriately to our principals through the Nigerian Governors Forum. On the right is the website of the forum. So for those who may be who may be interested in downloading the report, please feel free to go to the website to do that. And finally, here I am saying thank you for the opportunity, and I look forward to questions or comments. Back to you, Kevin.
Thank you so much, Dr. Filani, for that really interesting and comprehensive presentation, and just really wide-ranging across the whole set of health system functions. So we're now open for Q&A, and so I would ask participants to just raise their hand or put their questions in the chat. And while everyone is gathering their thoughts, I'll take the moderator's privilege and just kick us off with the first question. I wonder if you could just talk about some of the challenges. So we sometimes hear that an important challenge in Nigeria is kind of the fragmentation of institutions and actors in the health sector. It's not just the Ministry of Health, but it's the NPHCDA and the National Health Insurance Scheme, and then there's both the federal and the states, which have important roles, as well as the LGAs. And I wonder if you could just talk about some of the strategies you used at the state level for kind of coordinating, what does it look like from the state commissioners of health office to coordinate these different actors, and what challenges did you face and how did you address them?
Okay, so good point. I think there were very clear discussions between myself and the immediate past governor before I joined, and the same with the current governor in terms of the authorizing environment that I was allowed, and just the signaling in terms of people recognizing that the work I do is to ensure that the state is able to move in the right direction, right? So that allowed us to take a bit of politics away from it. The second then is just understanding how the administrative structures work, right? Again, like you rightly mentioned, multiple players, different agencies, different heads. In Ekiti, slightly different because they are led by civil servants, so the reporting line is a bit more structured to the commissioner. But I think very early on, again, like I said, we had, immediately I came in the first 2 weeks, we had a retreat that allowed us to do very clear deep dives and understand what the issues were. We meet regularly on a quarterly basis as a health sector, right, to ensure that everybody's carried along and understands what needs to be done, what is happening in the agency, in the State Primary Healthcare Development Agency, what's happening in state health insurance, right? I constantly drum it into everyone's ears that it's one health system. There is no SPHCDA, there is no Ministry of Health, right? So people see that what I call seriousness of mind. People recognize that the governor also is very keen on health. And so that's allowed us to work together without bitterness or any sort of, minimal, what I'll call minimal disruptions of any sort. I think also is, I recall the director of finance about 9 months after I'd came into my office one day and was smiling, and I said, "What's the problem?" It's like, "I don't know how you do it, but our budget always gets released." And I asked him, "Well, it's because I don't think that you've been sending it to the governor, right? Because you need to get approval first, right? So just helping them to improve the absorptive capacity within the system is also helpful, right?" And they recognize that, well, now if we actually write the memo and get it to the governor, it gets passed, right? It gets approved, and we can go to our finance to ensure that it's cash backed, right? So I follow up aggressively on that. So it's really 3 things. I had very clear discussions with my principals around authorizing environment. I had, formal and informal engagements with the heads of the agencies to ensure that, we're able to meet and everybody sees that it is one group and we can work together. And thirdly is that I'm available at any point in time, right, to just see through things. My office is always open.
Fantastic, thank you. I'm going to now pause and just let others jump in with questions. So just use the Zoom function to raise your hand, put a question in the chat, or you can just unmute and raise your voice if you have a question. So, and I see a lot of GHP 212 students out there, so look forward to questions. But I see Dr. Pate has a question, so please go ahead.
Oh, thank you, Honorable Banji. I think for an excellent presentation and the good work that you are doing in Ekiti State. I just wanted to highlight, and perhaps you may shed light a bit on the intergovernmental fiscal transfers and how that enables or makes difficult the financial situation at the state level. Your presentation highlighted the constraint at the state level in terms of your resources, the operational funding, and all of that. But within the context of Nigeria, the intergovernmental fiscal transfer, to what extent is that a key determinant for what states spend? And what are the challenges with that? And in recent times, I think it'll be interesting to hear your perspective.
All right, thanks a lot, Dr. Pate. For those who may not know, Dr. Pate was the former Minister of State for Health in Nigeria, and I had worked with him as a technical advisor at the time. So just a couple of things here. The first is it's a real challenge in Nigeria. States typically most states, bar 2 or 3, gets close to 70% of all their resources from something called a federation account, right? So in Nigeria, all resources, whether it's VAT, whether it's receipts from oil sold, crude oil sold, all resources come into a pool and then shared to states, well, shared by federal, state, and local government. And this creates a problem particularly in more recent times in the last 1 year, because first, there's been challenges getting money into the federation account for different reasons, subsidies and a few other things. And that has impact on the way states are able to plan accordingly, because then if the funds don't come as a when due, it has the cyclical approach has an ability, it limits your ability to plan your cash flow. From our perspective as a state, and I think more broadly now speaking in my role as the chairperson of the Commissioners Forum, it remains a challenge. And it's something that, again, like I mentioned under the Nigerian Health Commissioners Forum, is that we're able to work more closely with our colleagues in the ministries of finance at the state level to be able to address some of these things. And in addressing it, there's a couple of things. There's addressing to ensure that the budget processing is realistic enough, right? And not just full of fancy things that need to be done. Is ensuring that, the execution, which includes, the approvals that need to be gotten, the warrants that need to be gotten, the cash to back it, come at the right time or within a time frame that is clear, and that we in the sectors are also then able to deliver. But also in addition to that is that what most states try to then do now is there's an increasing interest in looking at opportunities to generate internal revenue in Ekiti. Our goal is to expand that by another 40% over the next 2 years, and we've been very aggressive about that in terms of what we need to do. So, for instance, in Ekiti, we've set up something called the GIS mapping that allows us to all properties in the state have now been marked, so we can adequately then say, what we call ensuring that the property taxes essentially are paid, appropriately, and that allows us to put some more resources into the pot. Federal institutions that are in the state, for instance, that have not paid their payee tax, right, or their personal income tax in a long while, we're aggressive about making sure that comes into the pot. We're working closely with the local government as well to ensure that we are better able to help them collect their revenues, and then maybe just hold up the cost of collection for that, so that because they don't have as much capacity as states would have, right? Revenues and market revenues within, transport and some of those other things. And it's not just Ekiti that is doing this. A host of states are looking into all of these options to expand the fiscal space that they may have that would allow them to be able to put in enough resources for development. I hope that answers the question.
Thank you.
All right, so we have a couple of hands now. So first we'll take a question from Kemi Wunme.
Okay, thank you so much. Thank you, Honorable Commissioner. It was really, really impressive to hear about all the things that Ekiti State is doing. I'm from Nigeria and I'm from Ondo State actually. So it's very impressive. And I think what really stood out for me was what you spoke about, financial protection. I think that's a major problem. Having worked in the public health sector in Nigeria, I know that catastrophic health spending is a major issue. And I just want to know what you think the major challenges of the Ulerawa service package you spoke about would be, particularly in terms of sustainability. We have the NHIS, we have people on private insurance, and now this is a special package from Ekiti State government. And I'm just curious to know what you think the challenges would be when it comes to sustainability, and also what you think the challenges would be when it comes to reaching the most vulnerable in your state with this package.
No, that's an excellent question. And the way I typically answer that is it really does start from, what you define as a package, right? If you have a package that is not reflective of the realities on ground, either from a disease burden perspective, either from the ability of your facilities or your health system to be able to deliver them adequately, or even from a cost effectiveness point of view, then what you just have is a wish list, right? So this is a package that really recognizes that the chunk of services required by people in Ekiti State, can be delivered in a primary healthcare facility. So this package takes into consideration 70, just a little under 75% actually, of services that people go in for, right? So it starts with a benefit package. And then having done that benefit package, we did a really robust analysis of the cost implications of that package. But beyond the cost implication is also the expansion pathway for that package. And we're realistic about what we could achieve. Are we able to cover everybody? And what would that mean in terms of the resources? And so where do we start from? The conversation I've had with His Excellency, for instance, is, look, if we need to cover 3.6 million people, this is the reality, because this is how much it costs per person, right, per capita to do that. So what we're doing is something called progressive realism and progressive universalism, right? Recognizing that the package We want to ensure that everybody in Nigeria, in Ekiti State, is covered. And then once that is done, we can begin to, if the resources allow, we can then begin to cover and include more services into the package. So sustainability, again, like I mentioned, is clear, explicit package that is guaranteed. 2, realism around the funding that you have, and government is committing to that in 2023 to expand the program. 3 are the potential opportunities that you could have. The Basic Healthcare Provision Fund is one where federal government has resources to buy a set of, to guarantee services for Nigerians. But what we're saying at the state level is that first, the services, right, the packages between the federal and states slightly differ. They may be a bit more, a bit of difference. And we will continue to engage with our colleagues in the health insurance agencies as to the opportunities to utilize the resources coming from federal, right, to deliver on the state package, which allows you to cover for more people, right, versus a package that is super big, but then covers for less number of persons, right? So there's always that trade-off, right? And it's just being clear, either to your friends in finance or to your governor, right, or to the different players, that it's always a trade-off to be made. And these hard choices are the realities that we face. Thank you.
Our next question is from Akinjide.
Yeah, well, it's evening here in Nigeria. Good evening, everyone. Thank you, Honorable Commissioner, Dr. Filani. I'm always amazed, about on your brilliance, right, at delivering, on quality stuff. Right. My question is like an overlap on what Temilumi just, asked. It's about sustainabilities, right? So if you look at this package that you've mentioned, right, it seems as if though, and please you can correct me, that there's some form of subsidies, right, from either state government or federal government in the form of, the BHCPF that you have mentioned. So my question is, have we thought about, having, to test an alternative healthcare financing? How popular would that be, right, around resource reallocation? So I am thinking of, right, instead of, the government taking up, the burden of, subsidizing, cost. We know these resources are scarce, especially the budgetary allocation to health. Have we looked or thought through about doing like a deep dive, financial modeling around, even if we can't, do a total privatization of this primary health care, post or primary health care health post? Have we thought about doing a PPP to free up some funding, particularly from, the budgetary allocation, for recurring expenditure, so that we can have a lot more, more fund, for capital expenditure and all of those, right? I feel if we go into, some private partnerships, right, we could have enough money, right, to now cater for the citizens as against, spending on salaries and then buying drugs and all of those. I thought there could be, some sense in resource reallocation, through alternative healthcare financing. Thank you.
No, you're spot on to the extent that there are many ways to, expand the fiscal space. And one of them is what you refer to as allocative efficiency of the existing resources that you have. The second and a couple of others are things I talked about, so as we expand the pie, right, or increase the bigger pie, then there's a higher probability that more resources also come to health. Even if the percentage is retained, the reality is if the pie is bigger, then you get a larger chunk that comes to health, right? And part of what we're doing in Ekiti is a very aggressive push to ensure that we expand the pie. I talked about the GIS earlier on to ensure that we're able to get some property taxes, but also some of the work that we're doing at the working with the local government level so that we can bring in some, generate more revenue. If the state generates more revenue, then it has more capacity or resources to be able to spend on development. And for us, we're very clear, we understand that's direct nexus between health and human capital development. So there's a commitment to health in this regard. So it's not for resource mobilization, essentially, it's multiple tools and levers that you have to pull to ensure that you mobilize the resources. And once you're able to do that, then you begin to pull and then purchase. Thank you.
Our next question is from Tayo.
Thank you very much. Good evening, everyone. Thank you so much, Honorable Commissioner of Health, for the insights you've shared so far, but also to the school at Harvard for facilitating this. I had two questions. The first was around, could you please shed more light on the opportunities that the new National Health Insurance Act in Nigeria could offer your state in, I would say, amplifying access and expanding coverage to the package of services that you mentioned earlier? What are the initial steps you're taking to explore complementarities and opportunities that the new act can offer? But also, as the vantage points that you have being the chair of all the health commissioners in Nigeria, is moving forward over the next 1-2 years, what do you see as potential bottlenecks for operationalizing that act? And what are some of the mitigation strategies? And the second question is a little bit around the supply side of things. I'm wondering if you have, or if you're considering any potential efforts to improve quality of care at your service delivery points, your health facilities in Ekiti State, and what your plans are around that. Thank you.
Thanks a lot, Tyre. Good questions. So on the first one, yes, again, like I mentioned, we're engaging very heavily with the NHIA, the DG of the National Health Insurance Authority. First and foremost, there is already an existing federal program using aids of fiscal government transfers to support, to provide services for people across Nigeria. The current challenge with that, which is the Basic Healthcare Provision Fund, the current challenge with that is that it is not near enough, it's not even close enough to helping to cover the entire population, right? So that's one. Secondly, is that the package in itself it's a good package, but given the realities of the disease burden in Ekiti State, this is one package that one can play around with to ensure that we cover more people, right? But we'll continue to have that discussion with NHIA, recognizing that they currently cover a cohort or a subset of people in the state, and our goal is to ensure that everyone is covered. The second question is actually a really good question. I think a number of things there. The realities in terms of risk in couple of months, we'll be having an election and a new set of people will come into power. With a new set of people means that there may be new set of, people in the health sector, right? So there are realities as to how they interpret, the act and how they want to set that going. So that's one risk. Risk number two is, the implications of a new government on deciding if they want to prioritize healthcare, right? And in prioritizing healthcare, meaning that would they even want to fund the Basic Healthcare Provision Fund versus, say, funding treatment for cancer or buying long-lasting insecticide treatment, or even putting the entire money into agriculture, infrastructure development, right? So there's always this. That's the second risk that I can identify. The third risk, of course, as always with these things, are, maybe the evaluation of the current Basic Healthcare Provision Fund, impact evaluation that may be associated with it comes out and the results don't give us a good sense of what is going on, or doesn't show or demonstrate that the program in itself looks solid. And so people say we want to scrap it. And how do we mitigate against that? I think, again, it's in our capacity as the Health Commissioners Forum. The first is, haven't just finished the Primary Healthcare Financing Forum, right, with very clear deliverables as our next steps, which I mentioned, engaging with our colleagues in finance, making sure that we feed forward with the commissioners, with the governors, is that by May 2023, right, as states, we should have a clear position as to how we think that, federal can help improve health outcomes, but also access to care. And this is bipartisan. This has nothing to do with whether you're in Party A or Party B, because the Health Commissioners Forum in itself is bipartisan, right? It comprises all commissioners, right? And so having that clear report is powerful enough, not just from the commissioner's point of view, but also then you can use the NGF, the Nigerian Governors Forum, as the what I call a a bridge, right, to engaging the presidents, the new president or vice president who may be leading the national economic team at the federal level. The third around quality of care, and it's a good point you raise. Maybe I didn't bring that up because I focused on three things there, but that's something that we've also been working on in the state, and all our secondary care facilities, as an example, we've moved away from using paper-based to ensuring that, well, not all, but most of them, we've moved away from paper-based to electronic medical records to optimize, service delivery and reduce patient waiting times. We hold our PHCs accountable to data reporting, and we adequately review the quality of the data that is reported. And where we see that they fall short or that maybe there may be issues, we always stress test that using something called a performance management system. But of course, not everything is good, right? Because the pathway is always a journey, right? And there may be a couple of times where things appear to fall below the crack, but our goal is to ensure that we hold people accountable to a certain level.
All right,
Thank you.
Just looking to see if there are any hands. So I think we have a few minutes left. I don't see any hands. Maybe I'll just pick up on the theme that you brought up in that last set of comments around the coming elections, and go back to something you mentioned in the beginning, which is that you've just seen a transition of governorship in Ekiti State, and maybe just ask you to reflect on that. In the health sector, we always say political will is important, but we sometimes act like it's really just a kind of roll of the dice. We might get a governor who wants to focus on health, we might not. But actually, many times we see actors in the health sector proactively engaging with political leaders to sort of manage these times of transition. So transitions can be, dangerous for health, but they can also potentially provide some opportunities. And I wonder if you could just share some reflections about how you've managed these political transitions, either in Ekiti or just throughout your time in the health sector.
Yes, so my approach to these things are, your technical capacity can only get you so far, right? So if it gets you through the door and you get on a seat, you then have to deliver, right? You're only as good as your yesterday. So whatever you did yesterday no longer counts, right? So you have to demonstrate results. And I recall when the immediate past governor, when we had a discussion, back and forth almost about 2 months, right, whether I was going to come or not. I think for me, I had an idea of what I could do, but it was also important to get that commitment from him. And I think we try to demonstrate very early on, the capacity. We pulled as much of my support and relationships that I had built in the past at the federal, right, to be able to support the state. Because one of the things that was just lacking in Ekiti from the health sector perspective was we just didn't have partners, right? And so just hearing that partner X had come and is supporting on Y, partner B is coming to do X, just gave it a bit more oomph. Then also that people then felt that, they could actually put together proposals to request for funds, and those funds were coming out, because that was a commitment we got from His Excellency as well. And what that did was, it's almost like a positive feedback loop, because as we're doing all of this, the citizens were responding to it, right? Recognizing that, oh, we're saying something different. Looks like, work is going on. We can see that the hospitals are responding to us. If we want to get care, there's someone there, right? Or this has changed. And so that feeds back again to the governor, right? And it feels, okay, if people feel good about the work that we're doing, then we should do more in that regard. So that cycle goes on. For Ekiti State, for instance, the new governor was part of the previous government. He was the secretary to the government, almost like the Secretary of State, a similar role, and then just became the governor. So he also had seen, how things work, but also he's a very committed person to health. And he also recognizes very clearly that, there's a link between health and productivity and development. And so if we invest here, then we can, it has, multiplier effects on, productivity and, the economy of the states. So when he won his election, he called me aside and said, look, we have to talk. And, we had a conversation around what we could potentially do. One of which is, of course, to expand the Ulerawa program to ensure that we have as many people as possible, particularly the poor and vulnerable in Ekiti, are covered under the program. I think for the national, in terms of maybe one point on this is, there's a citizen's role to this. But also in that citizen's role is actually helping people to understand what they should be asking for. Otherwise, you're asking amiss, right? And how to, the narrative, how to shape the narrative for your request and for the information you're sharing is always critical. And I think this is where a lot of people miss it. I could be telling 5 people the same thing, but recognizing what their interests are or how, where their background or the perspective is, then the narrative changes for that. So if I'm speaking to you versus say, I'm speaking to a woman in the market versus if I'm speaking to a completely different subset of or cohort of people, right? The same message, which is we want to ensure that everybody gets access to care, but I would deliver it in slightly different message ways that resonates with the people. So I think that's something that we need to be able to do better to ensure that citizens also are able to speak, to power and, hold politicians accountable to that. But again, like I mentioned, the role of the NHC, the Nigerian Health Commissioners Forum, although a relatively young forum, is becoming increasingly more, if properly utilized, more powerful. Powerful in the sense that you have the opportunity to really shape, right, towards the future, the next set of new generation of, almost like a health financing leaders within government and outside of government who know what should be asked about, who have access to data and can make those sort of like informed decisions or to guide the, negotiations and engagement with politicians.
Well, thank you. We're just coming up on 2 p.m. and I know it's late in Nigeria. So I think I see one final question in the chat, but I think we're actually going to have to close it here. So I would just encourage, if there's additional questions to please engage offline. But let me just ask you to join me in thanking Dr. Filani for joining us and for this really fascinating presentation. And I'm sure we'll continue to follow your work. And thank you again for coming today.
No, thank you so much for having me. I'm most grateful for the opportunity, and I hope that it's been useful for everyone who's joined on the call.
Thanks so much, everyone. See everybody next week.